Dr. Gary Sykes, obstetrician at the Sydney Adventist Hospital. We talk about the onset of labour when there are regular uterine contractions that cause the cervix to change. Change means to dilate, and to thin out, we call that to efface. Now, when taking an obstetric history from patients, sometimes they talk about how with their previous pregnancy, their labour lasted for a number of days. Often they're confused because a lot of these contractions were more to do with what we call an irritable uterus rather than true labour. In other words, the contractions were not sufficient to cause the changes in the cervix. So we talk about the onset of labour when these contractions cause the cervix to change. First stage labour is when the cervix dilates. Second stage labour is when the cervix is fully dilated, and second stage labour ends with the delivery of the baby. We talk about passive and active second stage labours. Active second stage labour is when there is maternal effort, the woman is actually pushing. Passive is the time before that. Third stage labour is from the delivery, the time from the delivery of the baby to the delivery of the placenta. We consider normal progress of first stage labour as being, if a woman's in her first labour, about 1 centimetre an hour dilatation progress, and if it's in her second or subsequent labours, it's about 1.5 centimetres per hour regular progress. If the progress is less than that, it usually means the contractions are not optimal, and so we will encourage the woman to agree to having a hormone infusion called a syntocinon infusion to augment the contractions and make the contractions stronger to help facilitate a normal delivery. Some women are hesitant because they're fearful, but what that ends up happening is she can have a long labour, a very long labour, and then being very exhausted by the end, and it makes it harder for her to push the baby out. Second stage labour, active pushing, we tend to limit to about 1 hour. But that doesn't mean that all second stages last an hour. Indeed, second stage labours can last a lot longer than that, particularly if a woman has an epidural. If a midwife phones me and says to me that this lady is fully dilated and she has an epidural on board, but the head's still at a relatively high level in the pelvis, I will encourage her not to encourage the woman to push, but allow the head to descend before getting her to push, because if she gets her pushing too soon, particularly with an epidural on board, that will increase the likelihood of needing an operative vaginal delivery. She'll run out of steam, and with an epidural it's hard to push more as efficiently. So if you allow things to happen, and when the head's quite low, then encourage her to push, then you'll find the majority of these girls end up with a normal vaginal delivery without any need for an operative intervention. Labour progress is quite unpredictable. I have no idea how it's going to go. I had a woman recently, she's a beautician, and she arrived at the hospital, first baby, fully dilated. So she could have come a bit earlier than that, but she wanted to stay at home to do her nails and do her hair before she got there. And she had three contractions and normal delivery, no stitches. Every woman's dream. Now, if you'd asked me antenatally if she was going to do that, I would say, I don't know. I had no idea. She's just a normal lass and no special reason why she should have such an amazing good childbirth experience. You get another lady who has a very difficult childbirth experience. Similar build, similar size baby, but it goes longer. She needs medications to syntocinon augmentation to make contractions stronger, and sometimes she may not be able to push the baby out. So we need to be flexible, and whatever is the case is the case. But again, we focus on the ultimate goal of a good outcome for the mother and the baby with a minimum intervention that's necessary.